Zosia Stanley serves as a senior vice president and deputy general counsel at the Washington State Hospital Association. WISHA represents all the hospitals in Washington state and works to improve the delivery, quality, accessibility, and affordability of healthcare. Zosia provides legal counsel to WISHA and advocacy for hospitals and health systems on legal, legislative, and regulatory issues. Zosia is a board member of the Washington State Society of Healthcare Attorneys and regularly presents on Washington State health law topics. Turn it over to you, Zosia.
Okay. Can you hear me okay? Sounds good. All right. Appreciate now I can do the mic and the clicker and all the things. So, my all right. Tell me if I'm too loud or not loud enough. So, thank you all for having me again. I was here last year and it's nice to be back. As mentioned, I'm Zosia Stanley. I am the Senior Vice President, Deputy General Counsel at the Hospital Association. Here today to focus on what happened in the 2026 legislative session in the state of Washington. And there's some, I was saying people like mixed outcomes, good, bad, otherwise, but a little bit more certainty than when I was here last year. So that's also a mixed bag, but at least we have some information. So have about an hour together. I will save some time at the end for questions, but I am delighted to take questions as we go through. I can listen to myself for an hour, but it's more fun to have a conversation. So please ask questions as I go. All right. All right, we need the clicker. So before we get into the session, a little bit about WISHA. The Washington State Hospital Association, our mission is to support the mission of hospitals across the state of Washington, and our vision is to be an indispensable resource and trusted voice to lead, challenge, and assist our members. So as you can imagine, being in healthcare, lots of opportunity there in lots of different ways. Really proud to say as an association, we have universal membership of hospitals in Washington state, so it's 114 hospitals. Every state has at least one hospital association, but they don't all have every hospital as a member. So we're really proud of that and do a lot of work to maintain that opportunity to speak with one voice on behalf of hospitals in the state. So this is one of our most popular pieces of information. This is a map of where all the hospitals in the state are. So we have members that are big hospital systems, little critical access hospitals, public hospital districts, behavioral health hospitals, etc. So we kind of run the gamut of all those hospitals. Also, the military and the state psych hospitals are members of the association. So objectives today, we will talk about the results of the 2026 state legislative session, talk a little bit about the healthcare specific outcomes. I will say, when you listen to people talk about the outcomes of legislative session, they all will bring their own lens. So we're going to talk about hospital healthcare perspective, but if you were to talk to the environmental folks, the low-income advocates, others, you would get different kind of highlights. So I'll give you my highlights and happy to answer questions. We'll also review some of the coming impacts of H.R. 1, the One Big Beautiful Bill Act at the federal level, because when I was here last and when I've spoken to conferences the last year, there was a lot of like, it's coming, it's probably going to be bad. And we have now a little bit more detail that it will be quite impactful and negative for Washington State specifically. So we'll talk about that. And then with all of that background, do a little bit of time to talk about what we expect in the 2027 legislative session and beyond. Okay, so the 2026 state legislative session just wrapped up on March the 12th, so pretty recently, although those of us who worked in session are feeling a little bit more relaxed this year because it was a short session. The way that our state legislature works, it's a biennial structure. So there's a long year, which is a 105-day session. Always starts the second Monday of January. The long years are the odd years. So 2025 was the long year. And during that 105-day session, the legislature has to both pass policy bills that it chooses to pass and also pass a 2-year balanced budget with a 4-year outlook. In a short year, even year, 2026, only a 60-day session, which feels it's very much like a sprint versus a marathon. And in a short session, the obligation of the legislature is to pass policy bills and do supplemental budget work. So hypothetically, you're doing less strenuous budget work during a short session, but in past years, the legislature has done pretty substantial budget work every year. So that is what we often see. Coming into this legislative session and the 25 legislative session, we were seeing and continue to see, I think, some really significant deficits in our state budget. There is real concern about the forecast for the state revenue being less than what the state would like to spend, which, as with maybe with the federal government, but most of us appreciate, you've got to balance your budget and figure out how to pay for the things you want to pay for and where to get the money. The first part of the budgeting process kind of coming into session is for this governor of the state to propose a budget, and that's usually has to be a balanced budget. Governor Ferguson, he proposes budget. He did a mostly cuts budget, not all cuts, but it was a lot of cuts. So that's kind of where we came into session looking at that budget. That budget is a proposal. It's not the final, but it's kind of where the governor's indicating he or she thinks the state should or could go. Then the legislature, being independently elected individuals with their own passion projects, takes that information, often disregards it, and then does their own kind of budget analysis. The bottom row here is the other things to think about going into the legislative session, which started on January the 12th. So one, hospitals facing really significant cuts and taxes from the 2025 session. We were the only industry that had both cuts and taxes placed upon us, and that was a really big concern coming into the 26th session to say, hey guys, this is a big deal, and also you got out of town in April of 25. HR 1 was passed in July of 25. So you did all these things without appreciating what was coming at the federal level. None of us actually appreciated what that was going to look like, but now you have that information, so let's think about that going into the 26th session. And then the hospital sector is one of the sectors in the state that has lost the most jobs going into to the legislative session. So that was, I think, a help about. It's not a good not a good fact, but it is helpful to kind of contextualize where we are as an entity. The other thing to be aware of, right, is the Democrats have some very strong majorities in both the House and the Senate. The governor's a Democrat in the state, so the Democrats kind of have pretty broad control. In case you're interested, in the House, it's a 59-39 split with the Republicans. In the Senate, it's a 30-19 split, so pretty significant majorities. And we'll talk about a little bit about this in a bit, but the Republicans then have kind of the power of the minority, which is not a ton, right? They're not in charge of budgeting. They're not in charge of a lot of policy bills. They have minority representation in the committees, but they do have some power to delay things or to put amendments on bills. So we'll talk about how they use that during a session. Another piece of context that we were really careful to think about and communicate as we're going into the legislative session is the financial fragility of healthcare in Washington state, especially our hospitals. We have, coming out of COVID, we didn't see any hospitals closed in Washington state because of COVID or during the COVID pandemic, which was a real testament to the work that those hospitals did. But coming out of COVID, we had some real brittleness in our financial health of our hospitals and healthcare systems. And so we had seen more cuts and service line cuts and staff being laid off. And we have a lot of data. And I'm looking at Jason Mitchell, who's our CFO. Sorry, Jason, I totally plugged in my last name. But anyway, Jason is our CFO, who can give a little more context if you're interested. But we have a number of hospitals that don't have a healthy margin, right? That are not at a place where they are doing well financially. And so we did a lot of talking with legislators to say, I totally appreciate you are looking at really tough financial situations. But the thing is, please don't look at hospitals as a source of additional funding or a source of additional cuts, because we are at a place where we are not able to bear those moving forward. So budget outlooks and negotiation. As I mentioned, Governor Ferguson came out with his budget, which was mostly cuts. Didn't have a lot of relief or kind of additional funding for hospitals, and did propose some additional cuts in the area of site mortality. And the House and Senate, they then, right, the governor does his budget. The legislature starts about halfway through the sessions when the House and Senate start kind of proposing their own budgets. They generally didn't take Ferguson's proposed cuts. They had a couple additional cuts. They were proposing, at least on one side of the budget, to cut most therapies for Medicaid patients, so speech, occupational, and physical therapies. And the challenge with that is, appreciating you got to find money somewhere. But what that means for Medicaid patients is that they are not able to get as healthy as they should be and be able to discharge from hospitals and get the best care that they can. So we opposed that part of the state's budget proposal. In the end, the final budget, $80.2 billion in general funds, and the legislature thinks in billions, which is interesting. And what this includes is a number of things, right? So in order to get a balanced budget, they had to draw from the rainy day fund. They had to balance, they decided to balance over 2-year versus a 4-year outlook. Most states don't do a 4-year budget outlook. They do a 2-year budget outlook. And interestingly, many fewer investments in this budget. We often will see lots of passion projects about people saying, you should invest in new programs and new social services and new et cetera. We didn't see as many of that this year. Most of the worst cuts were avoided in the state budget, which was a testimony again to our ability to say, this is the reality of where our healthcare system is. He's very thoughtful about maintaining access to healthcare for patients needing hospital services. I will say a couple other things just of note. We'll talk about this when we get to the HR1 discussions at the federal level. There are coming cuts to cleaning the system on the exchange for affordability of healthcare coverage. There are going to be people who will lose their Medicaid coverage, and there are, I think, a lot of cuts that will come for patients who are undocumented or non-citizens. So we are going to see more people lose their coverage. The legislature, I think the state generally is trying to figure out, if we know that we're going to have hundreds of thousands of people who will lose their healthcare coverage, what do we do about that? We probably can't just say everything's fine, this is fine. We can't rely on hospitals to cover that with charity care or otherwise. And so the state has been thinking about, what do we do about that? How do we create a safety net for those patients who may move on and off coverage? That could be things like a high risk pool. It could be, reinstating kind of the basic health plan. But most of those ideas take money, and we don't have a ton of money to be working with. So there's still, I think, a lot of concerns about what that will look like. The other thing the state has to do to prepare for HR1 is figure out how to operationalize the HR1 Medicaid requirements and the SNAP, the food benefit requirements. There's a ton of money that has to go into like IT services and process things so the state can understand who is a Medicaid patient, who's an expansion patient, when are they going to be turning off and on Medicaid. So more to come. But this, I think, was probably the best possible budget outcome that we could expect. And we'll see what happens in the coming sessions. All right. So revenue and policy bills. So starting with the revenue. As I mentioned, the legislature came into town and said, we do not have enough money to cover all the things we want to do. So that means we have to either cut our spending or find new revenue. Washington State is a pretty regressive taxing structure. We don't have an income tax. We have lots of other taxes. And as I mentioned, the kind of Republican minority who has been saying, hey, appreciating you want to think about a more balanced, the Republican Party would say, one, you're spending too much money. But two, if you need to find more money, think about a balanced approach. If you're going to put more taxes on people, then remove some of the other taxes. I think the Democrats have been less interested in removing taxes, but they've done a little bit. So the big headline, of course, you probably all saw, was the millionaires tax that was passed this year. This is very much the kind of tax the rich glee of trying to get funds or money out of people who are perceived to make a lot. I will say that this one was a very interesting bill, right? There's a whole constitutionality question, which is Washington State doesn't have an income tax because we have a state state Supreme Court opinion that says you cannot do that. It's inconsistent with our state constitutional language. There's an interesting analysis that says, nope, it's okay. We can have an income tax, and we did it this way. So we have there will be a 9.9% tax on personal income above $1 million. It's effective January 2028, allegedly, although I will say there is definitely ongoing court battles. There was a referendum pursued that was not going to move forward, but there's at least one lawsuit that was filed, I think, late last week. And so my guess will be, I'll go back so you can see the actual language, possible the first payments will be due in 2029. Unless the law is delayed, if the plaintiffs get a delay or a stay, we'll see. So this was an important part of the state's budget outlook. So the state is assuming this will happen. A couple other taxes that were proposed not passed. There was a payroll tax, 5% payroll tax on businesses or employee wages over $125K per year. Didn't pass, but I think a lot of businesses said it's a challenge when the employer has to pay the tax, and we appreciate why you would do that because it's not, then you have that argument whether it's an income tax or not, but it's a challenge for employers to add yet more process there. And then, as I mentioned, the state's trying to figure out, if I see the coming wave of HR1 cuts, I see people are going to move off insurance or churn back and forth onto or off Medicaid insurance. What do I do about that? Interesting proposal on a Medicaid employer tax. This was kind of framed as like a Walmart tax or an Amazon tax. But interestingly, it hit a lot of businesses, including hospitals. This proposal would say if you have somebody who is an employee of yours who is on the Medicaid rolls, then you need to pay the state for the equivalent of that insurance. And it was interesting from a hospital perspective to say, appreciating what you're trying to do, that you're trying to figure out a safety net for these populations, you're essentially taxing the hospital and then paying them for the Medicaid services. So that doesn't seem to be a very sustainable way of doing that. This bill did not pass, but I think it'll be interesting to see what happens in 27 and 28 when the legislature tries to figure out what to do there. And the last thing I'll say on the millionaire's tax, again, to that point about the kind of minority Republican, what they can do. This bill, when it was brought to the floor for its final vote in its final House chamber, there were, I think it was something like over 40 amendments on the floor, and every amendment to a bill has to take, it takes 10 minutes ish, más o menos, to get the amendment kind of just through the process, not including everyone wanting who wants to talk about amendments. So the Republicans hung a lot of amendments on the floor, or tried to hang them on the floor of this bill, and it took them 25 hours of debate. That is the longest debate ever on a bill in the Washington State legislature, and they were real tired. And that, because they spent 25 hours on this bill, they didn't get to a ton of other bills. So it's an interesting kind of tactical approach that the Republicans have been taken to kind of slow things down. But the majority Democrats are pretty strong, and as long as they kind of align all their folks together, they can move most of the bills that they're interested in. All right, moving on to policy bills. So 340B, obviously a real big issue for hospitals in Washington State and healthcare providers, federally qualified health centers. The 340B program, right, is a federal initiative established in, I think, the early 90s. Requires pharmaceutical manufacturers to sell outpatient drugs at a discount to eligible safety net hospitals and healthcare providers, and that those savings are then used by those providers to provide care to their communities. This is a big, big fight between pharma and healthcare providers because there's a ton of money at stake. This is a federal program, but states have the ability to regulate some of the process cases within the state. So, interestingly, just as a side note, the pharmaceutical companies in nationally have been kind of gearing up. We've seen maybe a dozen states who passed various bills on 340B in the last couple of years. And in anticipation of this bill coming up in the Washington state, pharma hired most healthcare lobbyists in the state, which means they are conflicted from working in support of the bill. So we have a ton of people who lobby on behalf of hospitals, but in the end, on this bill, you only had very few people who could lobby on behalf of this bill. We were big proponents of the bill. We think it was a good idea, and it prohibits drug manufacturers from discriminating or limiting sales or planning reporting requirements on 340B entities or their contract pharmacies. In the end, and as a result of negotiations, the other thing the bill does is require some pretty substantial reporting by hospitals and drug manufacturers to the state. So we'll see how that works out moving forward. And there is already litigation filed. There are 2 lawsuits filed to stop this bill moving forward. The pharma manufacturers have filed some pretty substantial lawsuits, which they've done in most states. So we'll see how that goes. So far, I think they sought an injunction to stop the law going forward. They were not successful yet, but we'll see how the litigation plays out. Interestingly, because this is now a law that the legislature passed, the Attorney General's office is in charge of defending the law. So I think they will have a lot of work that they will be pursuing on this bill. Another area that the legislature worked on this year that WSHA was a big proponent of was what we call payer business practices. We have some pretty good data from hospitals and healthcare providers across the state that show payer business practices are really resulting in either hospital patients not getting care because of prior auth delays or questions about whether things should or shouldn't be covered, but also a question about timeliness of payment. So a hospital will have a contract with the payer, have provided the right care, have done all the things, and then wait to be paid for 30, 60, 90, 120 plus days. So we were a big proponent of this bill that was passed this legislative session. We're very proud that this was one of them. So this is the prior authorization transparency bill. This one gets at the issue of the prior auth process being just bananas and takes a long time, and potentially you will have gotten the prior auth, done all the services, and then the payer will say, actually, you don't really think that should have been off, so we're going to change our minds. We have also seen more of a battle of the AI bots in this area, where we have payers who have AI tools that they're using to kind of run prior auth, and then we have hospitals and providers who are kind of trying to do the same thing, use AI tools. So one of the things this bill does is to say, look, you need to have an actual person in charge of your prior auth decisions, a person with the qualifications to meet the decisions, to look at the proposal, etc. The other thing I'll say that was helpful in this bill is that it does prohibit some of the retrospective denials or changes to an approved prior authorization. One limitation on this bill, it does not apply to Medicaid, and in part because, as I mentioned, coming into the state legislative session, there was no money, and if you put new obligations on the Medicaid plans, the healthcare authority has to do things about that, and that costs money. So a number of these bills that were about payer business practices don't apply to Medicaid because of the state fiscal impact. Another one that we were big proponents of, very glad that it passed, is the modernization of time of payments. You'll probably be aware for commercial plans in Washington State, there's a requirement that the payment be done within 30 days for a clean claim. But that only applies to 95% of the carrier's claims, which means that you may have, it might be in compliance with that, but it means that usually a ton of like the bigger ticket, bigger cost claims will be hanging out there for a long time. So this bill requires that health plans pay clean claims within 30 days. And if it's not clean, promptly tell the provider that and either say, I'm denying this because it's not clean, or I need more documentation. And it really narrows the timeline for all that communication to happen. This may result in more claims being kicked into a denial, but then at least you get into a denial and appeals process, which has really clear timelines, versus being in limbo and hoping that you'll hear from the provider or from the payer. The other thing this does is it does have a penalty baked into the legislation. So the longer that the payer doesn't comply with the timelines in the bill, the more that they have to pay in the end. There's also OIC penalties for a failure to comply. And then another one that passed this year that we're pleased about is a requirement for network adequacy for MCOs or the Medicaid side to have network adequacy for skilled nursing facilities and rehab hospitals. MCOs have network adequacy requirements for behavioral health, primary care, lots of other things, but not for the long-term care side that they cover. And that means that we see Medicaid patients stuck in hospitals longer than they should be because there's not a network for them to transfer into. And most SNFs will say, I mean, I'll do a one-off contract with the payer, but it takes a long time and it's a painful process. So hoping that this will move patients into the right care setting more promptly. Another one that you're a proponent of that did not pass this year was a requirement for carriers to actually engage in contract negotiations if there's going to be a change versus just a notice that says, hey, by the way, I'm changing my contract. Here's a little notice, and I'm sliding this into a monthly newsletter or the bottom of an email that you may miss. So we wanted more clarity and more clear process between the parties on that subject. Didn't pass, but we will continue to work on that topic. Then under the kind of header of healthcare services and providers and staff, EMS staffing for interfacility transports. This is an interesting issue that came from a couple of our rural hospitals who said, look, sometimes I have a patient who is with me who I need to transport to a higher level of care. And if I can, I'll usually use an air ambulance because it's fast and I can rely on it. But there are times when either the air ambulance is grounded or they don't have the staff. And then I, at the hospital, am supposed to work with my local EMS to get that patient to the next care setting. But that state law says I have to have an EMT or a paramedic plus a nurse who is also certified as an EMT. And most nurses say, I'm a nurse. I don't want to have more certification. That takes a long time, a lot of time, treasure, and talent. And so then the hospital was in the position of saying, well, I need to move this patient to the next care setting or to their higher care setting. And I can either not do that, which is not a good result, or I can send a staff member with them who's not meeting the state certification requirements. And then I may be breaking the law, which is not our goals. So we clarified state law to say, look, you can send a nurse who has the appropriate training. We don't have to also be an ENT. And then we got another bill passed that we were supportive of that's about IV contrast administration, kind of the supervision aspect there. Previously, our state law didn't really align with CMS requirements. So you had providers and hospitals saying, like, I kind of would like to do this more flexible approach that CMS allows, but our state law is a little bit antiquated. So we were pleased to see that pass. And then there's always a lot of hospital regulations because hospitals, right, are very complex, highly regulated, as they should be. There's a ton of really complex care that happens there. But we often will see proposals where we say, I appreciate where you're going, I get where your goal is, but we don't think you can get from where we are now to where you want to go with that proposal. So we do a lot of negotiation on these types of bills. So there are two that we negotiated on that we were pleased to support or be neutral on. For hospital inspections, there has for a long time been a weirdness about the Department of Health statute said be like, you inspect hospitals on an average of every 18 months, but maybe not on a third blue moon, or maybe not if somebody else is inspected. So lots of kind of confusion about timing. So this bill clarifies that timeline. It also allows for more clarity about which third parties can do, which accredited organization can do the inspection and kind of stand in the shoes of DOH or not. And then the other one was when we negotiated neutral. This is a bill to allow the use of medical cannabis for terminally ill patients in a hospital or hospice or nursing home. Absolutely appreciate the why of this. This came from a law that was passed in California a couple of years ago from a patient who had an experience of having really uncontrolled pain when he was not able to use cannabis as part of his care in a hospital. The challenge and tension there is that cannabis is still a Schedule I substance at a federal level, which means that it is like it's up there with peyote and heroin, and it's not something that we usually allow for use in hospitals. So we needed to make sure that this requirement could be balanced with our federal obligations. We have heard from the Trump administration they're going to move cannabis out of the Schedule I, but it has not been done, and so we are still under this current state of law. I will note one of the pieces of negotiation we did was to say, really careful how you define the patients who can access this medication in a hospital, and then making sure that the hospital and the staff of the hospital were not required to handle, store, dispose of, like, the people who are touching this type of medication. So I'm hoping that this will be a balanced approach, but it will be interesting to see where we go with the federal government and what they decide to do next. A ton of other bills or a number of other bills that were proposed that were kind of a similar, like, get where you're going. I appreciate what your goal is, but it's hard to get from where we are to what you are proposing. So flu vaccines in hospitals, most hospitals do offer flu vaccines to appropriate patients, but it will depend on, like the stay and the patient's needs, and this bill didn't have that nuance. I cannot pronounce this word. Phthalates? It's plastics. Basically a prohibition on plastics and like IVs, which is a great goal. We want fewer plastics in our lives, but there's not actually a replacement for those things yet. So we said, well, again, appreciate your goal, but like I don't know what to do. I can't replace all my plastics within the next year. Rabies vaccines in hospitals, again, very much appreciate. We absolutely want people to get vaccines and treatment. But this was kind of a bill looking for a problem. We talked to our hospital and said, look, we have rabies vaccines, or we have an agreement with a regional hospital to transfer that. It's not a problem we're aware of. And then there was one about patient advocates in hospitals. I think somebody had a bad experience of not feeling they had enough support to understand their options in a hospital. So they went to the legislator and said, everyone should have patient advocates available 24/7, 365, which is a great goal and also hard to operationalize. So I think these ideas may come back, but they weren't quite ready for passage this year. Bunch of bills concerned about, I think, framing around access, availability, viability, affordability of healthcare, which is a perennial concern. I think one that we very much share. Again, a lot of these are appreciating the goal and not sure that we can get from here to there in a reasonable manner. The top on the list is House Bill 2548 is an issue we've seen for the last 8 to 10 years. It's this question about what role or power should the state have to regulate and control healthcare transactions? So when a hospital and one hospital joins a healthcare system, or a hospital purchases or absorbs or aligns with a provider organization, or an out-of-state private equity comes in and buys a healthcare system or a clinic group, what role should the state have in that kind of oversight? Past proposals have been very strict, like the proposals where the AG would have power to approve, deny, condition, change transactions, which I can appreciate the appeal of that, because we want broader oversight about what our healthcare system looks like. The challenge with that has been that it has been pretty onerous, and the proposals would essentially, I think, cause most healthcare in its place in Washington State, which I don't think is what we want, just because of the time and affordability burden. So, bill this year, a different approach. This bill expands current pre-transaction notice requirements. If you are a certain type of hospital, provider, organization, and you're doing a transaction in Washington State, you need to give the AG notice about your transaction, and the AG will, within his or her existing powers right now, review that transaction and let you know if he has any concerns. The other bills here you all see did not pass, but took a lot of time and I think a lot of contemplation. So one is corporate practice of medicine doctrine, which is a court evolved doctrine in Washington State, which essentially says you need a license to practice medicine, and we don't want entities and corporations practicing medicine. We absolutely agree with that. The challenge with the bill is that, as proposed, we see this bill for a couple of years. It is not a rational approach, and it doesn't do the things it says that it does. Essentially, what it would do, instead of saying we want doctors to practice medicine and we want to protect that, which we all agree on, It did things like, well, we don't want the ability to have third parties help you manage your practice, or we don't want hospitals to be able to say this is our standards for clinical care or quality care. So we oppose the bill in its current form. I think the concept will come back, but it's one to keep an eye on. The next couple, there ongoing concerns about medical debt and the cost of healthcare nationally, which is absolutely appropriate. The challenge is that we tend to push down on little things and hope that the rest of the bubble doesn't push up. So things like no interest on medical debt, which again, I appreciate the rationality of that. The challenge is that doesn't appreciate that for hospitals, we have chair to care obligations to provide free or reduced cost care already. We get paid, cents on the dollar for a lot of insurance. And there is a population of patients who could pay for their bills and for whatever reason are choosing to not pay, to pay in a different time frame. And so the ability to add interest is impactful for those types of patients. So we did oppose this bill that would have prohibited all interest on medical debt. I think it will come back. Many states have done kind of different approaches here. Medical records fee caps. Right now, under HIPAA, patients can get their records for free or a very de minimis amount. Third parties like trial attorneys, sometimes will reach out to hospitals or providers and say, hey, give me this patient's entire medical record because I'm interested to see if there's a case here. And right now we can charge a reasonable amount for those for those third parties who are asking for the patient's medical records, obviously with patient approval, etc. This bill would have either prohibited or severely capped the ability to charge a reasonable amount for that. And the challenge with that is that it shifts the burden of cost from the third party onto the hospital to do all that processing and reporting. Charity care geographic restrictions. We've talked about this in the past, right? Hospitals in Washington state have an obligation to provide free or reduced cost health care to people who meet certain income and family size thresholds, which has been in place since late 80s, early 90s. In recent years, the Department of Health has said before 2023, most hospitals said absolutely, the obligation was we will provide free or reduced cost health care for anybody, especially anybody who needs emergency care. For non-emergency care that's hospital-based, you need to be a resident of the state or geographic area or like the WAMU region. Like hospitals could say, this is kind of who we want to support or can support in this part of our charity care program. Department of Health in recent years has said, no, we think that's wrong. We think you actually need to be providing charity care to anyone who comes to Washington state. And very much appreciating there's an equity piece there about people needing access to healthcare. There's also a balance of the financial burden that places on our hospitals. One of our hospitals in the Idaho border has seen, I think it's a 42-ish% increase in the number of patients from Idaho seeking non-emergency care at their hospital because they can get it for free or a significant discount. And I, appreciating Idaho has a different structure, doesn't have the same kind of coverage that Washington has, but it's a big burden on our hospitals. So bill didn't pass to clarify that there can be geographic restrictions, but I think that will continue to be an area of consideration. And then interesting questions about the role of certificate of need in Washington state. That's a state regulation that says you need state approval in order to do some kinds of healthcare services or build new hospitals. Elective PCI you guys are probably more aware of this than I am, but is a type of service that can be financially sustaining for a hospital. It's not allowed to be provided at other care settings like ambulatory surgical facilities. This proposal would have allowed elective PCI at different settings. Again, this is a proposal I think we will see coming back, but it wasn't quite ready for this year. Worker protections, tons of interest in kind of how do we protect workers either from ICE or from bad actors or bad employers. So this year, Washington state passed a prohibition on non-competition agreements. Previously, our state law said you can only have non-competition agreements if people make a certain threshold of income or above. So you couldn't use it for, lower wage workers, but you could use it for some of our higher earners. And I think tech companies have been very interested in that. I know some hospitals use them. A lot of businesses use them. Effective, I think it's 2020, June of 2027. They are void and unenforceable. And there's an obligation if you are an employer that has employees with non-competes, you need to get the notice saying, hey, by the way, we can no longer enforce that. it will be interesting to see what the impact here is. I think there's been some interest in the tech community of big tech companies use them. Startups would like them not to exist because then you can, transfer talent. So we'll see how this one moves forward. There was an interesting proposal around the role or the how to interact with ICE or immigration enforcement when they come to hospitals, schools, childcare settings. A lot of concern about enforcement and how that impacts staff and patients, students, etc. In Washington state, we had not seen, at least for hospitals, we had not seen a lot of ICE enforcement at our hospitals. I'm not aware of any ICE enforcement that's happened in the hospital. However, ICE does sometimes bring patients who are currently in custody into the hospital for care. And so part of our discussions on this bill was to really make sure we were balancing. There's a perception or some folks who want to say, we 100% disagree with everything ICE does. We want them not to be anywhere near our healthcare settings. And so you shouldn't allow them in at all. The balance there is that we have a lot of law enforcement that will bring somebody in, someone who's custody in for care. We don't want to exclude those patients from getting the care that they need because they're in custody. So a lot of discussion on this bill and this topic. I think it will come back because we continue to see real concerns about immigration enforcement done in our various states. A bill did pass around immigration worker protections. This one requires the employer to give an employee, a lot of employees, notice if they get information that ICE is going to do enforcement or immigration is going to do enforcement of the employer. This one I think this is a very popular bill, a lot of support for it. I will note that this requires a lot of notice and signage obligations on employers. So if you're an employer, just be aware that this is coming, these new requirements are on their way. And then an interesting one on workers' compensation about the right to seek treatment from a provider of a worker's choice, which I think I'm not a workers' compensation person. This seems to be a pretty big deal, kind of, how do you kind of manage costs in a workers' comp setting? AI. One of the things I really enjoy with legislators is asking them what they think AI is and does. And I don't know what AI is and does. I don't think they do either. But it's interesting when they propose bills and they say, well, I'm really concerned about this impact of AI, and so I'm going to propose a bill about it. I don't actually understand what it does. Oftentimes tech will get ahead of the law, and this is a point where the law is trying to get ahead of technology or to understand where technology is going. And I don't know that we're quite there yet. I do think it's a very interesting question about where is AI coming up in healthcare or in other parts of our businesses, our world as consumers. So there are actually more, but there are at least 4 AI bills to be aware of. One is about transparency, which is essentially like telling somebody if you are using AI as part of the process, and directs government agencies to inform, especially government, to inform consumers if AI is being used. That was the one that passed. There are a couple others that were interesting about like AI chatbots. And actually, I think there was one, I can't remember if it passed or not. There was one that was essentially saying like, if you're an AI bot or tool or whatever it is, you need to make clear that that's what you're doing. You're not giving, if you are giving medical ideas, you're not a nurse, you're not a doctor. You need to be clear that you're a bot, not a licensed person. The other ones I think are interesting are the high risk AI. And there's that question about where are we utilizing AI? And there's good reasons to use it, but where are we utilizing it in a way that we don't feel comfortable with, that we think that it's too risky to use? Things like healthcare, housing, education, access to various government services. This one I think will continue to percolate. There's a Attorney General's office task force that is supposed to be coming up with the state approach on AI. And I think this seems very silly, but one of the things they've done is actually define AI, which is really helpful because right now I think in state statute we have it defined in like 4 or 5 different ways, which makes it odd to try to figure out what the world of AI is supposed to look like. So definitely more to come in the world of AI. And then lots of other big ideas that either, passed, got kicked around, or didn't pass this year. The one I will note that's in this green box is the idea of the state trying to limit its liability exposure. You are probably aware, right? The state gets sued for many things. I think the biggest thing that is a source of exposure is when it comes to child protective services, whether the state did or didn't act appropriately. And there's some real big exposure there if the state did not act appropriately. And the statute of limitations is either non-existent or goes back many, many years. When I talked about the budget the state passed coming out of this session, About $1 billion of that state budget was going to cover state liabilities for lawsuits and settlements. So, Senator Dingera, who's actually from around this area, the Renton area, and is an attorney, was the sponsor of a bill that said, look, we think we should have a mandatory arbitration requirement if you're going to sue the state. And they do that in part because arbitration option will take out some of the cost and process when it comes to litigation and lawsuits. The challenge, of course, is that means that it can perceptually and probably factually feels like it takes away the plaintiff's ability to pursue their case and really bring a claim against the state and be made whole. The other thing, just from inside politics piece, is that the trial bar is a very, very powerful group in Washington state. They have a significant lobby, a significant PAC. They very much oppose this bill, again, because it would change the way that they do business. And there's a funny saying in Olympia that you never mess with King Tut, Tut being the trial bar, the unions, the teachers, and the tribes. So anytime you go up against those kind of lobbies, you will get some challenges. So this bill did not pass this year, but I think this idea will continue to come up for the state on how does the state manage its liability. I think a lot of people would say, well, you just need to not do wrong. Don't harm people, and you won't have that liability. I think the challenge, of course, is that the state acts by and through individual humans who can make mistakes. And so there's this balancing. A lot of states actually have this kind of either a pretty big statute of limitations, an arbitration clause, or some kind of limited liability, but we need to see what happens. The other couple things the state does was, one was about flock cameras. I don't know if you all heard about these. These are cameras that are used by law enforcement to track and record people's license plate numbers when they are driving in the world. That data, it's unclear kind of how long is that data kept, how is it used, who has access to it. There was an example that I don't know if it's apocryphal or not, but that story that gets told about Texas law enforcement using those kind of cameras to track somebody driving out of state to access reproductive services that would not be legal in the state. So lots of concern about law enforcement use of those cameras, that data. So Washington State did pass a law regulating and limiting the use of those kind of license plate reader cameras. And then I mentioned the AI piece. Couple others to note, the state did repeal a tax provision that allowed a tax deduction for data centers. Big feelings about data centers across the U.S., kind of where should they be located, how much resources did they take, what's the kind of, again, role in AI, lots of questions there. They had benefited from a tax break for a long time. And there's, I think the folks who were supportive of the tax break talked about the employment opportunities that those data centers can bring to rural areas. The opponents were concerned about the environmental impact, et cetera. So interesting there. The other one I just think is interesting is there's a big fight among electric vehicle makers. Apparently Tesla has for a long time has had an exception under state law that allows them to sell directly to consumers, versus Rivian and others had to go through licensed car dealerships. I just think it's interesting. It's just like just little intra entity fights that are I wasn't aware of. So they did get that. Rivian and others did get the same sweetheart deal that Tesla has. So a couple others to note, just so you are aware, we have the State Voluntary Treatment Act bills. None of them passed this year, but a lot of interest in what is the role of the state when it comes to taking away someone's rights in order to get them treatment? How sick? How do you assess that? He gets to assess what's the role of law enforcement if a person is a danger to self or others. Interesting fight in the, again, pharmaceutical world around the kind of GLP-1 manufacturers. Had a fight with compounding pharmacies about who should be able to make those kind of drugs. Interesting conversations about guardianship in the state, right? Again, you're taking away someone's rights. What's the process for that? What is the court role? Do we have enough people in our courts? We don't. How does that work? The Attorney General's office, we have our newer attorney, AGO, Nick Brown, who I think is interested in expanding the power, authority, and role of the AG's office. Our current governor, prior AG, I think also likes the concept of the role of the Attorney General's office. I think it runs up against, though, other law enforcement agencies and the question about what's the role of the state's law enforcement entity. They're also I think they're the biggest law firm on the West Coast in the AG's office. So interesting question about their power and authority. We were supportive of a bill around third-party litigation funding. This is the question about it is very expensive to get medical malpractice and liability insurance in Washington state. Part of that, I don't think it's all of it, but part of it is the fact that we allow third parties, private equity or otherwise, to kind of invest in plaintiff side lawsuits to say, I will back this lawsuit. And if you plaintiff win, then the third party I reap some of that settlement or amount that you recovered. It's an interesting question about like what's the role of a third party litigation funder? Should that be more transparent? Bill didn't go forward, but I think that will be an area of continued discussion. And then protecting health information or other information from federal reach. We have HIPAA, we have our state privacy laws, we have the SHIELD law, we have the My Health, My Data Act. Lots of attempts to try to protect our citizens, our residents' health data from federal reach. The challenge is that can be hard to do. You can definitely protect it from third-party litigants, from private parties who are trying to get data. But when the federal government comes in and says, hey, I'm a payer, I'm a public health entity, I'm a regulator, I need data on what's been happening at this hospital or what services you have provided, or give me information about all the providers that have provided abortion services in the last 6 months, that can be more challenging. And so I think the state's still struggling with how do you try to protect providers and patients from federal inquiries while still complying with federal laws. And then a couple others on tribal data, State False Claims Act. These are kind of more nuanced pieces, but it's an interesting question about kind of how are we sharing data, where are we sharing it, and what are the enforcement rights that people have. Okay, that was a delightful spin through what happened at the legislative session. Questions, comments, concerns? I will move on to HR 1. No, but yeah. Oh, good. You're well trained.
Dude, you're doing well. This guy's hustling. Okay, so kind of two-part question about SB 5981, the 340B
Okay.
protections.
I'll admit I didn't memorize all my bill numbers.
It's like from the first slide.
Yep.
So part one is what additional protections does this bill provide to 340B entities? And then the second part is, if I correctly understand that some hospitals are probably going to be losing 340B classification because of federal legislation, does this state bill preserve those entities' 340B classification, at least functionally?
Yeah, that's a good question. So on the first question, the kind of what's the what of the bill? So it prohibits the discrimination. It delineates, and Jason Hotchkiss, who's sitting next to you or near you, can probably also add to this. But it essentially delineates that says, look, you 340B entity can't make it harder you pharma can't make it harder for the 340B entity to participate in the 340B program or add new ownership reporting requirements. And the enforcement there is the ability to file private lawsuits. So it empowers the 340B entities to bring suit to enforce the state law. So it is an interesting question about kind of the loss of 340B cover or 340B status, I guess is what you would say. I would say I think it has happened to a couple hospitals, but it has been more about their payer mix or their patient population mix than Medicare, Medicaid, et cetera, commercial percentages. I'm not aware of a current change at the federal level that would exclude 340B entities. And I'm looking at Jason to see if I got that right. Not as well trained.
That's because I don't have real accurate information, so I was just gonna spin some stuff.
I like it.
We learned yesterday in one of the presentations that the dish measurement
Oh, yeah.
changes and goes up for qualification, and so those with less dish would potentially lose it.
Yep.
So there are some that are on that cut line that may lose it for that reason.
Yeah. So I think the headline for the 340B legislation in Washington state is that it is helpful. It provides some protections, but it is not a panacea. It does not address the dish cuts and the other things the feds could potentially do. No, unfortunately. Yeah, there's that interesting.
I'm realizing I could have asked for this.
We all iterate. We all gotta, we think these things through. I appreciate it. All right, I will continue HR1. Please ask questions as we go. Because HR1, I think these are more, reminders of where we are going or what we are going to see. We, right, the One Big Beautiful Bill Act, although it was big, it's not beautiful. Probably not just one. Probably going to get more bills coming up. Big picture, it does a number of things around healthcare benefits, especially around Medicaid recipients, the ACA marketplaces where people can buy commercial insurance at a discounted rate, and some Medicare implications. We expect hundreds of thousands of current Washington residents to lose their healthcare or to turn on and off healthcare, meaning they will lose it and get it back and not have continuity of care. Most of the big Medicaid impacts are going to happen in January 2027, but we will see other impacts that are happening either before, during, or after that time period. So this, and I think you've probably seen this one before, but this I think is a helpful chart of just what we are projecting either from directed payment cuts, loss of Medicaid coverage, or increases in charity care and increases in bad debt for hospitals. So these are real numbers that will continue to grow as we go forward, assuming that there are no changes to HR1 requirements. On the state-directed payment program cuts, these are programs that many states, including Washington State, use to essentially draw down additional federal dollars to Washington State to use those additional dollars to bump up the Medicaid rate that's paid to hospitals in Washington State. The challenge is that in HR1, they're going to freeze the directed payment program or provider tax programs and then ratchet down the amount of money that will be able to be realized from those programs. We just in the last couple of years had redesigned our state directed payment program so that hospitals were gleaning more Medicaid dollars, and it bumped up the Medicaid rate, and in the end, as a result, more access for Medicaid patients to hospital services. And this is deeply disappointing in HR1 that we are going to see this reduction, and as a result will be a reduction in the Medicaid rates that are paid to hospitals. So this, I think, is one that lots of states are going to have to grapple with, is what does it mean that we're losing these dollars? And do you replace them or do you just eat the cut, unfortunately? These are just a couple dates to be aware of, right? We are beginning to see the directed payment program free. We saw the freeze. It's going to start ratcheting. We'll talk about at the rural fund in just a moment. In October this year, we will see more lawfully present individuals who will lose their healthcare coverage. These are people who previously had been eligible for various programs, will not be anymore. In 27, you need to remember not to have two January 2027s because they're the same. We will see work requirements. That means that people who are Medicaid expansion populations, so people who are 100 to 138% of federal poverty level, they will have to start either showing that they have a waiver or showing that they are working a certain amount or volunteering or doing community service. And the challenge with that is I think that there's a great theory behind that, but it requires a ton of process and paperwork and proof and a whole new process for people who have not previously had to do that. And we have seen that paperwork burden can really mean that people lose their coverage, even if they have the qualification and they can prove it. The process piece is what will sometimes move a lot of their coverage. We will also see a limit on retroactivity. Right now, if you came to the hospital, got a ton of really intensive healthcare services, and then later on qualified for Medicaid, there's a retroactivity so that the hospital can get paid for that care that they provided you. There's going to be a limit in that retroactivity, and there's going to be a ongoing verification process. All this requires a ton of new work from the state, a ton of new obligations on Medicaid recipients, and will result in people losing their Medicaid coverage. You think 1 in 20 Washingtonians are at risk of losing coverage. That can be either on the ACH exchanges, the commercial insurance side, or the Medicaid side, and there can be some people who lose their Medicare coverage. The challenge with this is that this means that the people who are providing care are not going to be paid for the care that they provide, and people especially will not be able to access the care that they should be receiving because they will rightly be concerned about the cost of their coverage. This is something that the state's doing a ton of work and thinking about. WISH is also doing a lot of work and thinking about this. The challenge is that the feds have to pass some rules and regulations and structure and information about what this program is going to look like, and they have not done that yet. And so this is we are now in a state of some knowledge, lots of worry, not a lot of facts. So we are hoping, well, hoping seems very optimistic. There will be more facts. I don't know if they'll be good facts, but at least we'll have some facts as we go forward. So stay tuned. We'll have more as we go forward. Wanted to flag the Rural Health Transformation Fund. As part of the passage of HR 1, there was a conversation about, gosh, guys, we're really concerned about rural healthcare, rural hospitals. And rural hospitals said, yeah, you should be. This is a big deal for us. And so there was $50 billion annually for 5 years put into a pool with ostensibly to help rural hospitals. The structure is actually broader than hospitals. It's rural healthcare. There is, in each state had to apply for funds on the RHTP. Washington State applied. Wished it was a big proponent of that application. We're getting $181 million for Washington each year for 5 years. The Healthcare Authority is the entity that is kind of the state agency that is kind of implementing that world. There are, I believe, 53 hospitals that are qualifying for this money. WISHA actually has a role. We're part of the. We're going to have a contract with the HCA to help roll that money out. Have a process to get rural hospitals their funds. It'll be interesting to see how this rolls out, what this happens. Each state is kind of doing their own thing, little laboratories of democracy. So we'll see how each state does this. But it's hopefully going to be some sustainability for rural healthcare and hospitals. More to come as we move forward. And then the wheel will keep on turning. 2027 will come. The legislature will start again in the state in the second Monday of January in 2027. Is the biennial budget year. The state has to figure out its budget. State has to figure out where it wants to spend money, how to address HR 1 concerns, how to figure out lots and lots of things. So there will be more to come. We are in the process of the association of figuring out what are our priorities for 2027. I will say we definitely know already that we want to think about how do we figure out a safety net for people who are impacted by HR 1. We want to continue to talk about the financial viability and fragility and brittleness of hospitals. And we also want to be proactive and think about how to get people better access to better care in our communities. So if you run into a problem in Washington State where you say, that state law is wacky and I don't know how to, I think we could make a world a better place, please reach out to us. We can't always make a world a better place with some of these ideas, but sometimes we can. That EMS bill I talked about, that was a rural hospital saying, hey, this is wacky. Can we change this? And we were able to. So even if you're not a member of the association, please reach out if you run into something weird in Washington State. We can't always fix it, but it's really helpful for us to know what you are seeing. That is me. I am happy to answer questions now or later, or clapping. Yeah. Hi. Hi. Are the applications going to be released soon? And so do we have a date yet? For the RHTP? This one? Yep, thank you. Sorry, I should have been clear about that. That's okay. So the state, a bunch of ideas went to each state. Each state individually applied to the federal government for funds. And each state was, I think every state, most states definitely applied and were given funding. So that application process has, I believe, concluded at this point. Now it's onto the process of the federal government saying, states, you're going to get this money, but we don't have yet, we lack some details about the contracting structure. Was that your question? Jason may have a question or an answer.
So you're talking individually for the hospitals.
Oh, sorry. There we go.
That's all right. Once the contract with the state is complete and we know, and really the contract with the state and CMS is complete, then we'll know how we can, when we can open that up and apply for those dollars. So it's pending. We don't know an exact date because there's still a lot of moving pieces, but we're getting closer each day to settling the contract with the state, which would then allow us to create. We have the application created. We just need to finalize the agreement to be able to submit it and send it out.
Thank you for knowing what the questions and the answer. Yeah.
So I saw that Washington is likely going to apply for the waiver to not have to roll out the work requirements. My understanding is if that does come into effect, that's every 6 months, as well as the every 6 months redetermination that has to happen as well under HR1. Is there a risk that those could happen at 4 separate times throughout the year, or do you think either our state will try to align each of those? Is there a risk to other states doing misalignment, and all of a sudden now they have 4 different checkpoints for eligibility?
That's a great question. There's always a risk that states do wacky things, and each state is, again, a little laboratory of democracy, and they're all going to do different things. I think that, I don't know. I'm hoping most states will be rational in aligning those things. Right now, I think it's usually like on someone's birthday or on their enrollment day where they have to do those things. And so I'm optimistic in Washington State. I know there's a ton of thought being put into this around making sure that there's clarity and that the process is as streamlined as the state can make it and is least burdensome on individuals. So I think that's a healthy concern. And I think in Washington State, there's enough very good brains on this that I'm very hopeful that at least in Washington, they will not be every other month trying to figure something out. Yeah, I also think that the waiver it's really unclear whether the state says there'll get any waivers now.
And the recent information you received on that is that HCA or the state is planning on just using the individual's current redetermination date for all of those. So if somebody's next redetermination is until June or August or so of next year, they're not going to, currently the plan is to not change that at all.
But I think that there are states that are doing different things. There are some states that are accelerating and trying to get to these timelines before they're required. There are some states that, I think it was Kansas, has already had some work requirements as part of like a waiver, and that has not gone especially well. So yeah, stay tuned, and it will be interesting to see how each state kind of pursues this. I think Washington will be as rational as is possible. And I realize I am over time, and I will not keep you all. I realize that I am your last speaker of the day. I'm happy to answer questions offline, or you can email me, reach out. I'm always happy to connect, and I really do appreciate the opportunity to chat. Thank you.
Okay. Thank you, Zosia. So it's always a very informative presentation, so appreciate that.